Bueno, good morning, everybody. Welcome. Thank you for waiting. Buenos días, bienvenidos. Muchas gracias por esperar.
Welcome, thank you very much for waiting.
Panel on mental health, which I hope will be a really stimulating and exciting experience for all of us, given the wonderful group of experts we have assembled here. Let me introduce them very briefly, so we use most of our time for the most important part, which is hearing about their work. We are honored to have Lord Professor Richard Layer, who's an emeritus professor of economics at the London School of Economics, and he's also the founder director of the Center's program on well-being. And as you all know, he's been a very strong advocate of the inclusion of well-being as an important indicator in addition to other economic indicators. And his main work right now is around making well-being of the people a central objective of government. We also have Dr. Ma Hong from China. She's a professor and clinical psychiatrist at the Institute of Mental Health in Peking University, also the executive director of the National Center of Mental Health in China. We have Dr. Rubén Alvarado from Chile. He's a psychiatrist who specializes in social psychiatry and public health. He's a professor at the School of Public Health and the Faculty of Medicine at the University of Chile. And we have Niels Fiedje from the World Health Organization. He's a research officer at this organization in the regional office for Europe. His background is in English literature and cultural history of medicine. He is in charge of the Trust Medical Humanities funding strategy, and he's very interested in the cultural context of health and well-being. So as you can see, we have an incredible breadth, both geographically from Asia, Europe, Latin America, and also a breadth of experiences that will be very interesting to hear about. So we'll start with Lord Layard, please.
Well, I was delighted when I heard there was going to be a session on mental health, because I believe that if we could treat more of the mentally ill people in the world, this is actually the most cost-effective thing we could do to improve human well-being. This is quite a claim. It's quite a claim, but I think it's true, and I really want to persuade you of that in what I'm going to say in these next minutes. This is what I want to persuade you of, that mental illness is the biggest cause of misery, that it's scandalously neglected in every country, that there are huge economic costs of doing this, of neglecting it, that we can treat it effectively, and I'm going to prove to you that there would be no net cost involved in treating certainly common mental illnesses worldwide. And then I'll give you some details as to how we've been doing this recently in Britain. So this is the first claim. The most striking proof is that I've managed to find, which I find really shocks people. One needs to shock them. Is if you go to the United States, one of the surveys of the population in the United States, and you identify the most miserable people, the 10% of people who are least satisfied with their lives, and you find out what are the characteristics of these people. I worked most of my life on unemployment and poverty, but here are the facts. 27% of them are poor, 13% are unemployed, 14% are physically ill, and 61% have a diagnosis of depression or anxiety disorders. So mental illness is much the biggest cause of misery. I don't know if there's any politician in the world who would accept that. But we need to prove it. We will not get the resources that we need to deal with this problem unless we confront people with this kind of evidence. Here are similar data for Australia. But for most other countries, we have to rely on, in surveys, on the way people answer questions rather than whether they actually have been diagnosed. So here's a survey of the causes of life satisfaction in Britain. And it's based on a cohort study, so we can look at the immediate causes first. A person's situation here in midlife. What are the factors that are most influencing the dispersion of life satisfaction across the whole population? And you get some of the obvious ones like income and employment. Education, not very important for well-being, except through its effect on income. Family life, very important, physical health, but mental health is by far the biggest single explanatory factor explaining the variation of life satisfaction in the population, probably also explaining the variation of life satisfaction in this room. It's just the great ignored element, because it's subjective, but of course we are able to measure it. Now, the only other thing I want to say by way of causality is, of course, it's interesting to know how people came to have the adult characteristics that they have, which, of course, in many cases can be predicted from their childhood characteristics. So there are three main dimensions of child development: cognitive test scores, achievement, academic achievement, behavior, and emotional health. If we asked every school principal what he thought the main purpose of the school was, of course he would say to improve their cognitive achievement. But if we asked him to act on the thing which will most predict whether the person has a satisfying life after school, of course that's completely wrong. The best predictor is the emotional development of the child, next best the behavior, and academic achievement is of course important, but it is not the biggest predictor of whether a person will have a good life. So this is looking at it in the overall well-being context. But even if we just look at it within the context of health, mental health versus physical health, the WHO, well represented here, have this analysis of the sources of morbidity in the population. And there you'll see that heart disease, stroke, cancer, lung disease, and diabetes account for 22% of morbidity in the population, and mental illness for 38%. But if you then ask how are resources in healthcare systems allocated, in rich countries mental health gets on average 5%, and in poor countries on average it gets 0.5%. So a complete imbalance between the prevalence of the problem and the resources devoted to it. So this is my next point, that mental health is scandalously neglected. Let's just figure now on common mental disorders, meaning depression or anxiety disorders. Typically in most countries about 16% of adults would be diagnosable with these conditions, and of these only a quarter are in treatment in rich countries, and much smaller numbers in poorer countries. If depression is a more serious and debilitating condition than, for example, diabetes, asthma, arthritis, angina, 50% more disabling. But if only a quarter of the people with those physical diseases were in treatment, there would be an uproar. And we need to have an uproar, of course, over the way in which mentally ill people are treated. And one thing which helps in this uproar is that it's not only a humanitarian issue, which is, of course, by far the most important aspect. It's also a big economic issue. Because these conditions, and I'm focusing in particular on depression or anxiety disorders, they have huge economic costs, and I'm going to talk first about their impact on employment. So if you take the group of people who are classified as disabled, half of those are suffering from mental illness, mainly those common mental disorders. And of course, a half of the people in work who go off work and are absent from work are absent because of mental illness, and particularly those common mental disorders. And that applies also to the loss of productivity from people being at work but just not able to focus on the work, which we call presenteeism. So on a minimum estimate, these economic costs of mental illness are something like 4% of GDP, and of course they're a considerable cost to businesses as part of that. Also a cost to taxpayers who are paying disability benefits. But there's another equally important economic cost, which I think is going to help perhaps more in getting this situation remedied than this one. This is a situation where employers, treasuries are losing money, but to deal with it, the healthcare authorities have to put out more money, and they don't get the return back themselves. But there's also huge costs to the healthcare system itself in terms of the impact of mental illness on physical healthcare usage. So here's an extraordinary fact. That if somebody has got a given physical illness and they have a comorbid mental illness, their physical healthcare costs go up by 50%. They go to the accident and emergency more. They go for inpatient, outpatient treatment. These are out-of-pocket costs to the insurer or the healthcare funder. That's very serious. So the good news is that we can treat these conditions. We've had a revolution in psychology. We have psychological therapies now which can produce 50% recovery rates during the period of treatment and greatly reduced relapse rates. But the really important point for the advocacy is that there is no net cost of providing these therapies because of the costs of people being ill that I just referred to. So the cost is covered twice. These are our calculations. They're covered through the saving in increased output and reduced disability benefits when people recover through treatment for depression or anxiety. But they're also covered through the saving on these physical healthcare costs, which again cover the cost of therapy. In the US, there have been 28 trials that measured these numbers, and in 26 of them, the savings in the physical healthcare outweighed the cost of the psychological therapy. So based on all this evidence, we've been able in Britain to launch a major program to make psychological therapy more widely available. We have been doing it now for 7 years. We've trained 6,000 therapists to a high standard on a national curriculum. They have to be fully accredited, and they are now treating 500,000 people a year, and we hope this is going to double in the next 5 years. But the keys are, there must be good training. People will get much better results if they're working in well-supervised teams and not on their own. And the supervised teams need to be supervised by a psychologist or psychiatrist. And the most important thing of all is that we record the outcomes of every patient treated so that we know precisely the recovery rates, and that's what makes it possible to make the case for providing this on a larger scale to those millions of people who deserve a better deal than they have at the moment. You can read all about this in our book, 2 editions there, and here's another one with David Clark. Just end with a mention of our movement called Action for Happiness. and I was very glad to hear our chairman knows all about this. This is a movement for getting policy oriented on producing happier lives. When we interviewed the director, one of the candidates had gone into the web to see if there was any other organization on the web that had the word happiness in the title. And the answer that came back on his screen was, your search for happiness has produced no results. We can do better, and I do believe the most important thing to do is to treat the mentally ill people who are staring us there in the face. Thank you.
Thank you so much, Lord Layard, and what an example also of British punctuality to that. Thank you so very much. Dr. Ma?
Thank you to give me this great opportunity to share some our experience from China. My name is Ma Hong from the Institute of Mental Health, Peking University. Actually, I'm a psychiatrist, a clinician, but in the past 15 years, mainly work for the government to run the mental health program. So today I will share our experience about our program. That is a very simple but a little bit strange name. We simply call it 686 project. Yep. So this project starts from the 2003 after SARS, because during the SARS came to China, our government suddenly found in China we don't have a qualified public health team for this kind of issue. So they give a lot of money, try to build a team. They said they would like to spend 3 years' money to rebuild a public health team. Traditionally, mental health is not on the public health list, so no one thought we should be part of this project. But we are very poor for health. Mental health is even poorest area, so everybody wants money, especially us. So we're working very hard in that year for application this program. So finally, we got very small money. We shared just 6.86 million RMB yuan. Is almost equal $1 million now. So even the very small money, but it's the first time we got the central government funding, and we are one of the member of in the public health system. So we feel very happy about that. So I introduced a little bit before our project. Before that, mental health service like this, the doctor sitting in the hospital and the patient sitting in their home. So if they have to see the doctor, most people pay by themselves, because the medical insurance only covered the person who has job at that time. I mean, 2005, almost 10 years ago now. So is the patient be sent to the hospital and be discharged, sent again, discharged, so that they rotate. So the service is very isolated. And all the doctors are very, just used to be stay in the hospital. Sorry. Okay, so please don't take all this photo because it's a real patient photo I took by myself. The patients have the 2 places to stay. If they have small money, they be sent to the hospital. Like this, this girl's not sent by the family members. We don't know who put her just outside the hospital. So the hospital had to look after her, just, we don't know her name even. So for some severe with violent behavior patients, they have been locked, at home, So please remember this lady. I will show the another photo about her. She belonged here about 8 years. So our goal for our 686 project is just we want to build a community mental health service, then to link it to hospital to the patient stay in the community. So we need to build a team. Oh, sorry. Go back. Yes. So the procedure is like this. We designed like this because we learned this from the Australia model. So the first we think, okay, we had to learn something. Then we invite Australian people to train us. Then we link it to the service, to the hospital, to the community. Then build the team in community. Then put the patients either in the hospital or at home to get some treatment. So that's some details. We need a lot of new skills to working in community, then try to linkage, then build a team with we call general practitioner at that time, because it's, we don't have general practitioners traditionally. It's also almost the same time build the team, like mental health team in China, and the team providing the diagnosis by psychiatrist and the treatment use first line, most is a first line medication. So the challenge for us is the first is funding, because the central government's funding even increase every year, but it's not enough. So the matching funding must from the local government, but the local government, they don't want to give the matching funding. So that is always the challenge up to now. And the medical insurance is not covered everyone at that time. So only our project funding for the medication is not enough. And we don't have the network working with like psychotherapist or social worker and the stigma. Stigma is a very, very challenge problem because the patients and their family, mostly the family members, don't want to stay in the service because of stigma and no rehabilitation system at that time. And the bottleneck problem is the human resources. 10 years ago, we have 1.28 psychiatrists per 100,000 population. Now we have 1.82. Increase some, but still not enough, still very, very rare resources. And doctors lacking the experience of working in community. And for the system, we don't have a registration system. We don't know where they are. They can visit us today and move somewhere. We can't, it's hard for us to follow up. And we need training material, and just like the economic grab in China, we know the purpose, but we don't know the detailed procedure, how to get our purpose. So in China, we have a famous sentence, touching the stone, cross the river. Just we want to cross the river. We're just touching stone, cross the river. So some experience we learned is all the psychiatrists need to be training before they lead the community health team. And the most west part in China, we had to work to promote care together. Otherwise, we don't have enough person. And we had to training a family member to be a kind of case manager. And very important experience, we were lucky. We have two universities we're working for a long time. One is Melbourne University, and the other is the Harvard Medical School. We're working together for a long time. And what is the most important? Also, we have worked to the university in China. I mean, for the teaching hospital, they have a lot of experience to help us to prepare the training materials. And the most important thing is we did visit several countries, see their experience, but we had to bring them back to digest and do some modified to based on our situation. And of course, we have something wrong. We at the very beginning we also is complying the government not pay attention and don't give their money. So now we change another way. We're talking with their language, and our doctors to the even the PhD already. They back to a training being a public health, just like MPH, Master of Public Health. So we can talk in same language, and also. Yeah, we start a very small project. Now CCSS already covered the whole country, and the medical insurance almost covered 98% in China, even it's very low. And from this year, with our government is setting a new set for comprehensive mental health service in China. We got extra money. So now the system like this. This in rural area, the patients is here, they go a different way. It's based on the local situation. Maybe go to the hospital or the CDC is aiming Center of Disease Control and Neighborhood Committee. Then to reach, the service can done to the patient, and the information can go back to the hospital. So it's a linkage network. Some places are working very well, but not all. So that is the last slide. So that is that lady we locked 8 years. So she shows us she be locked with this, and the father held that is the iron stick. So she showed me they used to be locked. Now she has some drawer here, and it is her bed now. And I think not only herself got a light bulb, and also her parent and the neighbors, they felt very well now. Thank you very much.
Thank you so much, Dr. Hung. Thank you.
Muy buenos días.
Very good morning. First of all, I would like to thank you for the opportunity of sharing with you an experience that is specific to my country, Chile, and it is a program for the healthcare of people living with depression, and it was done as a primary healthcare program. This is in community centers. Very briefly, I would like to tell you that the focus that I have as a researcher in the University of Chile, this is the biggest public university in my country, my focus is in supporting the development of public policies using the tools provided by research, using information so that these policies be done or be extended to the rest of the country. I have used 4 specific experiences in this presentation, just as the ones in the area of mental health. And the last one refers to the use of tools that can allow us to assess the working places, or the places where we have psychosocial risks. And in countries like ourselves, these areas, or we have areas that are that present with higher problems. And based on this experience, as you can see in this slide, what we have done as an academic team is to support the development of those policies that are now used throughout the country. However, I also wanted to emphasize one, because I consider that it has 3 core aspects that can be of help and can be a lesson and can be a useful experience without a doubt, the process in policies implementation cannot be the same for every place because we have a different context, a different history. The features of each region is different, or are different, and this can only give us a general idea of what is possible here. I chose this one, as I told you, for 3 reasons, because one, depression is one of the biggest problems within mental illness because of how big it is and how it can be disabling to the person, and how it also is going to alter the surroundings of that person. And also, it was introduction of the first component of mental health as part of primary care in our country. It is a good experience. It is a process of how a policy was implemented, not only in one region, but in all of Chile. And I would like to focus on that, and how is it that we managed to get there? Because as it was said yesterday, our ambassador in the OECD, this data is very important. But not only is the data important, but also to have policies, services, to do actions towards improving those data. And not only the data, but how to get into action. That's why I want to emphasize this. And the third reason why I thought this case was very important is that because in this case, we were able to do assessments on this scaling process. Therefore, I can share with you more specific data on what were the factors, the contributing factors towards the success of this program. What is this program then? It is a program that was a pioneer. It was part of a primary healthcare. And I need to tell you a little bit more about it and to put you into context. This program started as a pilot program in the year 2001, and it started in 15 primary care centers out of 600 that we have in 3 different zones in the country. And back then, our country was not part of the OECD. We had an income of $5,000 per person, and our healthcare system covers the whole country, and primary healthcare is pretty much in all rural and urban areas. Therefore, it is a service that has a 50-year tradition. Therefore, it is possible to provide access to different types of medical care, and amongst this, mental care. And that's why this is a pioneer program. It has multiple components: psychological care, also pharmacologic care, and it was developed also with a clinical guide that was evidence-based, and it allowed the professional teams to have a guide to follow when they encountered a case. And these professional teams were obviously trained to perform this task. Basically, the program works as follows. In any of these 600 centers that we have throughout the country, we have a group of professionals. It is usually a GP, a nurse, a social worker, and a psychologist. And they are the ones who receive this person wherever we have a suspicion of depression. What this team does is they confirm the diagnosis and they design a working plan. This would be the first line treatment. If the person does have a major depression disorder, then they are going to be sent to a specialized team. And this team is also a community center that has psychiatrists and also social workers, but they are more specialized. And if not, they can receive antidepressants, psychotherapy, and group intervention together with other people that experience the same problems. Approximately 93% of the people are cared for, and they solve their problems in these first-line treatment centers, and only 7% go to the secondary level. After some time, some treatment time, and in the beginning we thought it would only be 6 months, and later on we realized that it could be a longer period of time. After this period of time they can get discharged, and sometimes if they exhibit complications, if they exhibit resistance, then they can be derived to the secondary treatment. This is just the general outlook of the program. What has happened in the last few years? Well, you can see in this graph, because we have a national registry that allows us to know how many people are receiving treatment. You can see here how it started in the year 2001 with this pilot group, and around 14,000 people. Well, I can't see very well, but this number went up as the years went by. And something that is very important here is that in the beginning, in that first phase, we did an assessment, and my team was in charge of that assessment. We did an assessment on the effectiveness of this program in real life conditions. We went to these primary care centers, and 2 years later, this was very important for the Ministry of Finance. That's the one in charge of allotting the resources to different areas. They were able to finance the extension of this program to the rest of the country. That meant that they had to hire more psychologists, and they had to allot more funds to get the medications. And as you can see here, throughout the years 2005 all the way to 2009, there was a peak, and afterwards it went down. And it is very much possible that we are now reaching a standby situation, and that's pretty much the people who are probably with depression, but who are receiving treatment. And we have a historical debt with mental health in our country. That's why I think that's why we had that peak, and now we are stable. I would like to just show you that just like in any other condition, like hypertension or diabetes, many people abandon treatment, and that reduces the effectiveness and the real impact of this community program, just as this one. And therefore, that's the biggest challenge to this date for this type of programs. You can see here that approximately 1/3, a little bit more than 1/3 of the cases abandoned treatment. And in the assessments that we did, we showed, as you can see in this graph, in the red and yellow lines, that the people who stayed in the program and received the treatment improved. They improved their depression symptoms. However, those who abandoned treatment had no change in their symptoms. I am not going to talk into detail about the statistics controls, because there are a lot of numbers there, but I just wanted to tell you that back then we assessed a couple of dimensions that have been very much discussed. This is life satisfaction with the Demon scale. It was 14 years back that. And we also use a scale to assess positive effectiveness. And we wanted to see whether or not these programs had an impact not only on depression, but in all other dimensions of well-being. And indeed, we managed to see significant improvements in both dimensions. Very well. As I was telling you, we have reported in different publications the results of this program. I am not going to go into deep. I just wanted to show you if you're interested. However, there is one that I am particularly interested in. What is it that made policymakers take the decision to scale this program and to extend this program to the national level? And what we did is that we did in-depth interviews of those key actors in the Ministry of Health. Those were key people who took decisions back then. And it is very important to tell you that it was 4 areas where the opinions of these key people I believe that those are the areas that truly were key to achieving this change. One of them was the evidence, the scientific evidence regarding the importance of this program and regarding the effectiveness of what it is that we are doing. I'm going to show you that a little bit more in detail. But there are some other areas, just as leadership and team building abilities, and also to create strategic alliances, and I am going to tell you specifically which alliances. And third, being able to design this program with the logic of a culture towards public servicing Chilean citizens, just as you would for diabetes or hypertension. And the core aspects of this evidence allowed the decision makers to get convinced were as follows. First of all, scientific evidence proved that depression was a public health problem, and pretty much 1/3 of the people living in Chile are going to suffer depression at some point in their life. We also know that in the last years, around 16% of adults suffer depression. This is a big number. And second, we also knew that amongst the ones who seek primary health care, close to 50% of these people suffered from depression. This was a very important point in identifying those cases and providing treatment to see those needs. Even though most of them don't go because of depression, they go because of pain or some other illness. Therefore, we need to train our teams so that they can look further and realize that there is something else, not just a headache or another complaint. And something that was also important is the assessment that we did, where we managed to prove that I would say that three things were very relevant here. First of all, we broke a myth that people in the government had, and it was a myth that depression was going to be useful for anything. And this means in Chile they believed that it was just going to be a big expense. This means that anyone could come in and get treated for depression. It would seem that 90% of cases would suffer from depression, but no. But what we managed to show is that they were being treated, that they were improved after treatment, and also it was at low cost. Back then, the approximate cost was $25 per month per person, and it is reasonable for our country. And third, and it was very important, and it was the way of how the team went about convincing the authorities. Not only was it important to have the information, but also to find a way to deliver that information in a clear, precise way with numbers. And that's very important, having the numbers. And as I can tell you, in doing it this way, we got good results. And as I told you, there were three other components: team work and leadership, the stability of the team. In Chile, it was a policy that was stable for 16 years. It is not common in our Latin American countries to see a team undergo such a long period of time, 16 years. Second thing is that alliances were established within the ministry, but also outside the ministry, for instance, the Ministry for Women. And because the problem of depression includes many women, and multiple problems can also be seen in these women. I'm not going to go into deep there. And it was a very important thing to realize. And third is to conceive mental health and the approach to this problem in a different way, something that was different to what was already in place in primary care centers. It was just like another program, just as you have programs for hypertension, TB, diabetes, the same for depression. It was very easy for all of these professional teams to understand how to do and how to approach this problem. Finally, first of all, we needed to consider this information that is very important, especially in creating policies, and to recognize the relevance of these problems. Without a doubt, we have enough information, but most of that information comes from those countries that have more resources to do research. Second, and this is something that I think is very important, is to have information on the effectiveness in real life situations, that is, to see how useful it is in our country, in our centers with our populations, not in control studies, but in real life conditions. And what are the costs also to doing that? Third, information related to the feasibility and sustainability. How can this be sustained over time? This is also very important because it is going to be of interest to any policymaker, and we need to answer to them every time we deliver information. And also the way in which this evidence is presented to policymakers in a clear, concise, brief way. Just 3 challenges that I think are important to mention. First, to maintain the conviction that mental health is important, especially that conviction with policymakers. I believe that it has been very significant to have a world forum, just as this forum for the OECD is very important to include mental health aspects, not only in the sense of how we treat people with mental health, but in general how mental health is a fundamental element in producing inequity, in producing poverty, and also transmit that knowledge to following generations. And also we need to establish permanent information systems, just as I was telling you, in different regions of the world. In our case, in Latin America, OPS has done it. And I believe that also a very important challenge has to do with respecting cultural differences, local differences, and incorporate citizens into the management of these information systems. It is a challenge. What works everywhere else not necessarily is going to work in every place, and that's something that we need to learn. Thank you very much.
So before I begin, I just wanted to say 2 quick words by way of an introduction. Firstly, the customary but also heartfelt thank you to the OECD for inviting me to speak at this event. And I really mean it because, secondly, I'm a bit of an outsider in this room. My background isn't in statistics or public health or even policy. Although I work at WHO, my grounding is in health and medical humanities. So I feel privileged to be given the voice at this table, and I hope that what I have to say won't be entirely incomprehensible. Although WHO is probably best known for its work in communicable disease and tobacco control, mental health is an integral and indeed fundamental part of how the organization conceptualizes health. From its beginning, enshrined in its constitution, WHO has defined health as a state of complete mental and social well-being, and not merely the absence of disease or infirmity. WHO is also well known for its data and statistics. Let me give you some sobering facts about the very real scale and cost of mental health challenges globally. Mental disorders are one of the most significant public health challenges in the world, measured by prevalence, burden of disease, and burden of disability. Suicide is the 2nd most common cause of death among young people worldwide. Even where mental disorders are not the direct cause of death, they nevertheless have a huge impact on rates of disability and mortality. For example, persons with major depression and schizophrenia have a 40 to 60% greater chance of dying prematurely than the general population. In fact, depression alone accounts for about 4.3% of the global burden of disease and is amongst the largest single cause of disability worldwide. Now, I could go on for the entire length of this talk throwing these kinds of statistics at you, but I'll end on this. The economic consequences of mental disorders are enormous. A study published in 2012 estimated that their cumulative global impact in terms of lost economic output will amount to about 16.3 trillion. That's 16.3 million US dollars between 2011 and 2030. So, spurred on by the growing realization of the burden of mental disorders worldwide, WHO has developed several global and regionally specific mental health action plans for the period of 2013 to 2020. These are high-level, aspirational, values-driven documents that set out some of the major challenges and misconceptions about mental health and mental disorder. I work in the WHO Regional Office for Europe, so I'm going to briefly focus on the European Mental Health Action Plan. It is driven by the values of fairness, empowerment, as well as safety and effectiveness. The plan's scope is to help improve the mental well-being of the population and reduce the burden of mental disorders, respect the rights of people with mental health problems and addressing stigma and discrimination, and finally, establish safe and effective services that meet people's mental, physical, and social needs. The plan has 7 objectives, which are shown on the slide, but which I won't go into. For each of these objectives, actions have been proposed for member states and for WHO that would achieve measurable outcomes in policy and/or implementation. But that's easier said than done. On the ground, the realities are vastly different across the 53 member states that comprise Europe. Some European countries lead the world in terms of vision and quality for activities. Several countries in the European region provide a comprehensive network of community-based services. But there are others which still rely heavily on the use of large mental hospitals for their mental health services, and who are struggling to implement these strategies. So this brings us to the second part of my talk. WHO's action plans frequently refer to the need for adaptation to the national and local circumstances. The Mental Health Action Plan is no different. It makes no qualms about the fact that the plan is only a framework, one that needs to be adapted in order to take into account country-specific situations. The actions proposed for member states have to be appropriately adapted to national priorities and circumstances in order to accomplish the objectives. There is no blueprint action plan that fits all countries. And yet, WHO doesn't have the capacity to systematically and rigorously assist member states with localizing action plans to national contexts. Although WHO has a spotted history of consulting with anthropologists and even historians about the specific cultural context of a particular health challenge, there is no infrastructure in place that allows for this information to be systematically gathered. It's not something that the organization, and to some extent its member states, have valued particularly in the past. In part, this is probably because WHO's main narratives of success have involved interventions which are, on the face of it, elegant and simple, like the eradication of smallpox or the Framework Convention for Tobacco Control. Now, of course, historians have shown how unequal, nuanced, and culturally complex these success stories were. But nevertheless, in popular accounts, they're almost always talked about in relation to 2 particular interventions, 2 straightforward magic bullets, a vaccine and a treaty. Acknowledging the importance of cultural context, however, destroys this illusion of simple biomedical solutions. It introduces a lot of messiness into healthcare. It is the antithesis of a magic bullet narrative. And yet we know that our experiences of health and our interactions with those who care for us are strongly influenced by the cultural contexts we inhabit. Over the past 20 years, a range of conceptual frameworks have been developed in the public health arena that examine how social and economic determinants intersect with an impact on health. This work has shown that the pathways to inequalities are not linear, but complex, and that the diversity of human contexts in which health is created and determined needs to be better understood. And still, despite all the work on social determinants of health, the concrete ways in which value systems, traditions, beliefs impact on health from bench to bedside are often ignored, as is the frequently positive, protective effect that culture and cultural participation can have in the face of certain health challenges. That's why a growing number of voices in the public health community have been calling for the need to reconsider the important role that cultural contexts play in the provisioning of equitable health care. In November of last year, The Lancet published an extensive commission report on culture and health, in which the claim is made that the neglect of culture is the single biggest obstacle to developing equitable health care. In the WHO European region, the rollout of Health 2020 in their European policy framework for health and well-being has initiated a shift towards values-based that emphasizes a life course perspective, intersectoral and interdisciplinary engagement, as well as a whole-of-society approach. Health 2020 has reintroduced well-being as a central component of its work, a move which makes WHO true to its definition of health and is re-engaging public health with the full complexity of the subjective, lived experience, and which has opened the doors to more systematic engagement with cultural contexts of health. The shift towards the subjective, as in the case of subjective well-being, is creating a new set of challenges for an organization whose functions is primarily normative and which is focused mainly on death, disease, and disability, not, in fact, on health and well-being in the broader sense. There's an increasing need to engage with experts who are exploring the meanings that people create around their experiences of disease, health, and well-being. In order to tap into this rich resource, the WHO Regional Office for Europe has recently launched a project on the cultural contexts of health. The CCH project is creating a platform which aims to systematically apply intersectoral and interdisciplinary research at the interface of culture and health to promote and facilitate the implementation of Health 2020. As an entry point, CCH is focused on how to measure and report on well-being in a culturally diverse European region where ideas about what constitutes well-being differ widely. An expert advisory group on CCH has been established, and the report from its first meeting has just been published. It's entitled Beyond Bias, Exploring the Cultural Context of Health and Well-being Measurement. Well-being and its cultural context is also the basis of a chapter in the flagship European Health Report 2015. And work is now underway to determine how best to better represent the subjective experiences of well-being using other forms of non-traditional health information such as narrative texts, historical archives, or other forms of cultural outputs. So, to conclude and to bring us back to the topic of mental health, I'd like to end with an example of how an interdisciplinary, cultural context-based approach to mental health care can help achieve some of the key objectives of the Mental Health Action Plan. The example I want to talk about relates to a specific mental health condition called auditory verbal hallucinations, a phenomenon where a person can hear a voice which no one else can hear. The project is called Hearing the Voice. It's based at Durham University in the UK and comprises a core research team of 18 academics from the arts to neuroscience, from psychiatry to cultural studies. The research team also works with an extended group of clinicians, mental health advocates, and people who have experiences of hearing voices. Many people think that voice hearing is just a symptom of severe mental illness, like schizophrenia or psychosis. What is less well known is that hearing voices is also an important aspect of many ordinary people's lives. Estimates of prevalency vary, but some studies have indicated that up to 1 in 6 people have experiences of this phenomenon in some form. There are many different aspects to this research. In addition to asking people what it is like to hear voices, the research team are investigating what happens to the information processing mechanisms in the brain when someone has these experiences. They are also exploring the ways in which voice hearing has been interpreted and represented in different cultures, religions, and historical periods. A process which is giving meaning to the phenomenon and an identity to the voice-hearing community. People can have a range of different reactions to hearing voices. A common reaction is fear and the thought that I must be mad. But hearing voices is not always pathological. Rather, research suggests that there is the stress associated with negative interpretations of this experience and ineffective coping strategies that can cause the most distress. This doesn't mean that the research is sanitizing suffering, but it does foreground evidence that hearing voices is a human variation with a long history. The results are helping to inform mental health policy and improving therapeutic practice in cases where people do find their voices distressing and when clinical help is sought. Fundamentally, though, the Hearing the Voice project does not take a magic bullet approach. Its objective is not necessarily to cure voice hearers, but to better understand the phenomenon itself, to tap into its culture, and to reduce stigma and suffering associated with the experience by giving a voice to the phenomenon which everyone can hear. So that might seem contradictory. On the one hand, the research team is trying to get a deeper historical, phenomenological, as well as neuropsychological understanding of the phenomenon in order to help manage the experience clinically. On the other hand, the team are helping to create a rich culture of voice hearing in order to help voice hearers and the general public accept the phenomenon as human variation. But is contradiction bad? Or is it not just a key principle of the complexity of human experience of health? If so, then dealing with contradiction can be seen as a fundamental strength of humanities research. Do I contradict myself? Says the American poet Walt Whitman. Very well then, I contradict myself. I am large. I contain multitudes. Thank you.
Thank you very much, Niels. Well, we have time. Thank you all for adhering to the time guidelines. So, this gives us time to have a conversation. What I thought we could do is first engage in a dialogue amongst the panelists. I would really like to know what your inner dialogue as you're hearing your colleagues, and then open the forum to questions from the audience. So, who would like to start? What stood out for each of you?
Well, I was very, very interested in the Chilean experiment because it's not so different from the one that I was reporting in Britain. Do you have a number of questions? Do you have a concept of recovery? I'm not a psychologist, I'm an economist, but I was very struck when I came to be involved in designing this program that David Clark, who is this clinical psychologist, really outstanding world figure, he was very keen that the concept of recovery is used. So we have the scales that people are assessed on at the beginning and after every single session, or actually before every single session, as an aid to the therapy, but also so that we always have a final score for somebody if they never come again. But we assess, whether people are proper cases at the beginning, and then whether they have recovered in the sense of having lost caseness by the time of their final meeting. And I'd be interested to know whether that is a crucial thing for you. The other aspect that we have found really rather important is good supervision. So although so we have a service in every area, which might have now about 40 therapists perhaps. And they will actually deliver their sessions in many different places, including the primary care practices, which are convenient locations, or sometimes in the school, or job employment center, or somewhere like this. But their loyalty is to this team. They get their weekly supervision in that team. Many of these teams actually have public supervision in the sense that colleagues see the problems of other colleagues. and we feel that works better than what we used to have before that, which was a primary care, a psychological therapy service where the general practitioner was hiring a therapist who really might claim to have some supervision, but didn't really have much supervision, and certainly the general practitioner was not in a position to supervise. So are your teams at all like ours in terms of supervision and the recovery concept?
Bueno, gracias por la pregunta, profesor Layer.
Well, thank you very much for your question, Professor. I need to confess something, and is that the health system of Chile, the National Health Service of Chile, was created in 1952, trying to imitate the National Health Service of Britain. And in many ways, our public system is very similar to the English system. It changed in 1981 when, after Pinochet's dictatorship, they introduced the neoliberal economic model, and they introduced private health services and private units. But the healthcare service in Chile is very similar to that in Britain. Probably that's why you recognized some of the similarities. These primary care centers work not with the idea of a precise recovery, and it is a huge topic nowadays because many people not necessarily required to reduce the symptoms all the way to improvement. Some of them, for instance, they can live with a certain number of symptoms, but they can live a normal life. Like, for instance, hearing the voice, that English initiative allows for people who we would call living a psychotic experience. They allow them to live a completely normal life and recover their roles in society and fighting that stigma, and as I tell you, recovering their place with their friends and family, and not necessarily do they need to stop hearing voices. They may continue, but they can also live a normal life. That's why we introduced these measurements. They were not set by me, but that's why we wanted to see whether people, even if the symptoms don't go down, their depressive symptoms don't go down, that their overall satisfaction does improve with life. Their close contacts with family and work, whether they improve, and if they improve the balance between positive affections and negative affections. And that's something that did happen, an improvement. But the very important question here is, we still need to introduce, not only in the area of depression, but in all other areas, the concept of recovery as a concept that goes beyond illness. It is a concept that has to do with living well. Even if I have hypertension, or if I live with diabetes, or even if I hear voices, or even if I feel a little down today,
severe mental illness, I completely understand what you're saying. But the most obvious case is anxiety disorders, because we know that with things like panic attack or social phobia, it's possible to completely extinguish these problems, and it's a very, very good objective for the therapists to have that high objective. And in most cases, with anxiety disorders, if they're extinguished, they don't recur. Depression, of course, is different because we know it has a recurrent feature. But there we, of course, have to be very keen on, I would still say, getting recovery from the present episode, but reducing the probability of relapse. So you didn't mention anxiety disorders in your presentation, but could you comment on that?
Sí.
I didn't talk about anxiety disorders because it was not the initial focus of that program. However, what happened in time is that many many of the psychological symptoms that they had with the diagnosis of depression were in reality a combination of anxiety and depression. And that's usually the case in primary care settings. And what was developed afterwards was a special guide in order to incorporate also the anxiety component, not only depression. But from the political standpoint, it was very important to focus in depression, because depression sensitized the policymakers, because there was very strong evidence towards the degree of the problem, the degree of disability. We know that it is also linked to non-communicable diseases, and that increases the disease load. Therefore, from the standpoint of public policies, it was very useful to focus in depression. But in reality, yes, what everyone is dealing with is with anxiety and depression together. Yes. Absolutely. And yes, there is higher effectivity there, but it is not full. Our tools, technological tools, both pharmacologic and psychotherapeutic tools, do not allow us to say that all cases are solved. That's also realistic. We do solve a big amount of them, but it's better than doing nothing.
Topic.
Well, I do have a question that I'd like to ask mine and Ruben, but I wonder if we maybe want to take some questions from the audience.
I'm sorry,
first.
I couldn't hear that part. Would you rather open the floor?
Yeah,
Okay. All right. Preguntas, questions from the audience?
Buenos días. Vengo de Michoacán. Mi pregunta es relacionada pues a tratar de mejorar la depresión. ¿Con qué acciones de primera instancia podemos contribuir la sociedad civil organizada a disminuir la depresión en las comunidades con contextos de violencia y pobreza, para así fortalecer nuestros diseños en algún programa que fortalezca, pues, incidir? Como dijo una…
Into account in this, so that just as it was mentioned previously, we cannot always complain. So just a line of action. Can you please support me here? What would be your first line proposal in order to improve depression in those communities living with poverty and violence?
Okay.
So
Gracias.
polite.
I mean,
A ver, es una gran pregunta, en realidad.
It is a great question. Yes, we would all like to know how to prevent or reduce the number of people that experience depression. To this date, we are still understanding depression, and we need to take into account the social determinants, just as it was mentioned by Niels, and it is part of the strategies of these multilateral agencies. There are measures that are generic measures, just as reducing poverty, reducing inequity, and so on. However, in the experience of Chile, and I believe that in other places as well, there are two aspects that I think are the critical points where we have the highest risk for the development of depression, or to make depression more possible in the future. One has to do with the first stages of life. And one of the big problems in my country is violence within the family. It is how they are mistreating not only physically family members, but also in speaking violence. In my opinion, it is a very relevant topic, and many times it is hidden. And I believe that we don't have full solutions for that. However, we need to work together towards building strategies, especially because violence is understood and has different degrees of acceptance in different cultures. In our country, we have a country that that apparently is very violent inwards, and this is something that is exhibited in families. So those children, we know nowadays that those children are going to develop response to stress that is going to be marked in them, and that's how they are going to respond to adversity, and that is going to make them more vulnerable to presenting depression 20, 30, 40 years later when they're facing adversity. I think that would be a very important focus. And the second point has to do with the working conditions in the adult life. Most of us are going to work, and despite that, nowadays we know something that was mentioned before. Not only the traditional risk in working, like an accident or contamination while working, biological risk, those risks are there. But nowadays we've developed a growing awareness that the characteristics of that work that had to do with mental overload, that has to do with having a confliction with the role that you play there, or suffering sexual harassment or different types of harassment, to being forced to doing something that goes against your values. Those are psychosocial risk factors, and those are driving factors towards mental illness like anxiety and depression. That's an area where we need to focus, because I think that most of us adults who are going to suffer depression, that's going to be a trigger point towards depression.
But if people have been exposed to violence, they will often get post-traumatic stress disorder. And we have very good treatments for this now. My colleague David Clark actually was called in by the Northern Irish government after one of these huge bomb explosions in which I think 90 people were killed and hundreds were injured. And he set up a service for treatment of post-traumatic stress disorder that had very, very good success rates. And obviously, in all areas of conflict, if we had adequate mental health services, this would be a very important part of their work. Just another comment on violence in the family. This is now recognized in Britain as a big issue. So over the next 5 years, we are going to be rolling out what is called couples therapy for depression, which is a very well evidenced treatment, and we will be producing thousands of therapists who can help in what I think is certainly one of the major social problems in all advanced countries, which is family conflict. And it's bad for the children, but it's also bad for the couple.
Ma, did you want to say something?
Sorry.
It's confusing.
Yeah, confusing. You know, I think for the if we're talking about the depression and disaster, I think China we have some experience to working for the depression after disaster, because normally people work with PTSD or something after disaster, but you know, we have a very big disaster, the 2008 Wenchuan earthquake. So many people died, 20 how many 200 and 1,000 people died almost. So then we started working in community-based depression prevention and some treatment. So, but our problem is suddenly so many therapists came to China from all over the world. So it's make the local people confused. Yeah. So we didn't build at that time. We didn't build a China-style therapist. So all the people they want to contribute to China. So there's a lot of training. So suddenly it's very very confused for the all the doctors. It's like a kind of another disaster. So after that, our government start to make regulation for the disaster psychotherapist. So I think it may be a way for the depression prevention and intervention after disaster. I mean, for the country like China, maybe it's a very good, how can I say, it's an opportunity to start talking about depression. Before that, it's very hard to talking depression, based on our culture. You just say you have something, you feel sad. Yeah, it's quite normal. So why is a kind of disease? So it's some my experience. Yeah.
Thank you. More questions?
So, 听不见了。
Buenas tardes. Miren,
Good afternoon. I think that the previous question was fabulous. I believe that this is a very focused panel towards correcting the disease itself. And I would like to ask Niels, what preventive measures do you have in order to improve, and not only health, mental health, but also physical, mental, emotional, spiritual, social health? And what are you implementing? Do you have something?
The truthful, honest answer is that the project that I'm leading on is in its early stages, the project on cultural contexts of health. So there are, I mean, the project that I talked about in terms of hearing the voices, I think tries to explain how a more interdisciplinary approach to some of these questions around mental health can bear fruit and can help us come up with more nuanced policies. But in terms of the project that we're working on, we're at the very early stages. But I do think we have the very strong belief that resilience to mental health issues, to mental disorders, is something that can be improved through cultural participation and cultural impact. So one of the things that we're very interested in looking at in more detail in relation to mental health is how culture protects people from episodes of mental health issues and mental health disorders.
Bien, disculpa, quiero terminar esta pregunta.
I would like to finish this question. I am a teacher, and many times my students, I would ask them to tell me the Holy Father, and they would answer the Hail Mary. And what I want to do here is to invite you to know a discipline that I'm developing in this area, because I receive many students with several problems, people who have been raped as children, people who have had several very major issues, people with the right hemisphere problems now are being taught with the left hemisphere tools. Many times if you are right-handed and you force a right-handed person to write with the left hand, that's going to be a problem. But what I want to do here is an invitation to the panel and an invitation to the audience. My project is called Being. I invite you to be and transform into beings that are physically, mentally, and spiritually healthy. This leads us to think about those things that we need in order to be physically, mentally, and spiritually, emotionally healthy, but as a prevention, not correction. I'm sorry to thank you. But it wasn't a question for any of the panel. No, it was an invitation for all of you so that we become beings that are physically, mentally, and spiritually healthy beings, and how to achieve that. And I believe we need to do that from childhood, because this is prevention.
It's absolutely crucial that our schools have as one of their goals to promote the well-being, the mental well-being of their students. I think actually this will probably only happen in certainly Western schools if we measure it. So we need to be actually measuring the well-being of our children as well as their test performance. Otherwise schools won't take it seriously. But what would a school do to take it seriously? It would have, of course, a code of attitudes and behaviors that everybody signed up to. But it would also have explicit teaching of life skills. So we can teach. We know we can teach resilience. We have programs developed by Martin Seligman, other people, social and emotional learnings. We are now trialing a 4-year program, 1 hour a week in life skills, called Healthy Minds. It includes mindfulness. It includes specific understanding of mental health as an issue which may arise in your family, and you should recognize it. This should be part of our basic educational system.
Briefly come in there, there's actually an interesting project that's now happening in the UK. University College London School has introduced or is using an RCT, a randomized control trial, where they're introducing mindfulness into the curriculum to see whether or not that introduction of mindfulness has an effect on the children, the students, and their ability to learn.
And sorry.
I think there's maybe something very, I think in China, maybe you can share with others. So the school mental health in China is still a very difficult area. So the one reason is based on our culture, the education system must be teaching the kids very positive way. Encourage them very sunny or something like that. If we're back talking mental health, especially depression or suicide, it seems very negative. So in our system, in our culture, in a school, it seems a very bad thing if you're talking suicide prevention or even the depression. So up to now, we still have the problem in this area. I think maybe it's just caused by culture. Yeah.
I wanted to add that there's, I think, like a worldwide interest in incorporating knowledge about, or research findings about well-being into education, things like positive education. And right now, as we speak, in another one of the panels, they're talking about a program that has been launched in Mexico, in public high schools in Mexico, to include social emotional learning. So I think that it is, on the preventive side, there's a lot of evidence how learning about these things decreases the chances of depression and later on in life.
Sí, sí. Quisiera extenderme porque esto me parece tremendamente.
Yes, I believe that this is very, very important to worry from early on, from childhood. And I believe that that's part of the prevention, and especially after the experience that you've shared. I would like to ask you, what is the possibility of incorporating measurements in the academic success rate, but also something that has to do with the development, not only in terms of achievement in mathematics or Spanish or biology, but also achievements in terms of how is my outlook of life, my life satisfaction, my spirituality. Because I'm thinking that what we usually use are PISA or big tests that are tests that only measure cognitive aspects. I believe that an interesting idea would be to start incorporating worldwide these other types of dimensions. How can we do it so that it is part of the measurements that we have for our schools? For schools that are raising our children. I believe that's wonderful.
Buenos días, mi nombre es Antonio Chávez.
Good morning, my name is Antonio Chavez, and I would like to ask you the question of whether any of our panelists recognizes the functions of the state in terms of prevention, whether you've determined in your several studies some areas of opportunity for that government, because there are clearly areas of opportunities, but we cannot treat the whole population. Ideally, we would prevent it. Do you have concrete actions, for instance, in Chile, where I noticed that you've studied this further, so that we can design the strategies or the policies that are necessary?
System, what we've been saying about the schools is incredibly important, and I think the state actually has always taken a view about the development of character. It's not new, but somehow or other it got extinguished recently in the obsession with test performance, but we need to reassert it, and we need to reassert it in the context of an age in which we only really treasure things that we measure. So that would be for schools, but then there's a whole other series of areas of life where you have an opportunity for prevention. When a couple have their first child is a very powerful and critical moment when you can educate both the parents in the mental health aspects of bringing up the child, and also actually of adapting in their own relationship to having children. So in business, of course, we need to have a much more well-being oriented approach to employment, where we have more civilized than in many workplaces system of relations where managers are appointed more on the basis of their actually ability to inspire people rather than terrify them, but also, of course, where we have actual courses provided. This Action for Happiness I mentioned is providing courses in workplaces to help especially middle-level managers to create a mentally healthy environment within which people can flourish. Every aspect of life, we need to see preventive activity, and some of it can be initiated by the state, others by the private sector.
Thank you. Maybe yours will be the last comment, Rubén?
Sí. Okay. Sí.
Yes, I am going to take the floor and on that end, and I would say that the responsibility of prevention is always the responsibility of the state. Prevention is a common wealth, and it is always the work of the state, but it doesn't mean that it's only the state. I believe that it needs to be done in conjunction with the population, and in that sense, I believe that it is necessary to develop policies that at the same time open possibilities and generate some freedom and some spaces that allow for the existing diversity. I believe that in Chile, we don't have everything that we want. Very little we have, but there is one initiative that I find very interesting. I mentioned that before, and it is called Chile Grows With You, and it was part of one of my slides, and it is a policy that gathers the services in the healthcare area and in education, especially preschool education, and they focus on a series of actions that go all the way from pregnancy, from the very moment that the person knows that is pregnant, and they start receiving healthcare controls all the way to 5 years. And they consider aspects like vaccination or feeding, the traditional aspects, but also they consider the identification of depression during the pregnancy or after the delivery, and that's how we are working together with certain tools, and that would help the teams identify the people involved. And we know that it is a huge problem. Approximately 25% of women throughout pregnancy and after delivery are going to suffer depression, and we know that that depression is associated with a slower cognitive development in those children, and it is also associated with the development of higher conflicts in those children when they go to preschool. So I believe that to focus our policies, you need to decide because you don't have money for everything. But if you had to focus on one thing, I would probably focus first in this period between pregnancy and the first few years of life of care for those children.
Our strategy for prevention, because China is a huge country, we do the same thing as public health. The first is raising awareness for public to the mental health law said to keep yourself mental well-being is your own responsibility. Then to educate all the health people, try to find the knowledge and skills to try to find the mental illness as early as they can. Then after be diagnosed, get the regular treatment, try to avoid to move to the disabled. So that's all.
Well, unfortunately, we have to end. Thank you all very much for your participation, your attention. Thank you, panelists. It was wonderful to be with you. Thank you.